It helps in their diagnosis, management, and other skills development. Let me invite Dr. Dalia, Professor, Department of Ophthalmology, Government Medical College, Alappuzha. She'll be talking to us on Lifting the Veil, a comprehensive guide to ptosis evaluation. Over to you, madam.
So good morning, all of you. At the outset, I would thank KSOS and Dr. Sija for giving me this opportunity. My topic is Lifting the Veil, a comprehensive guide for ptosis evaluation. Ptosis or blepharoptosis is abnormal drooping of the upper eyelid margin in primary gaze. And many serious diseases can present with ptosis, so we should have a proper practical plan to avoid missing potentially life-threatening causes, and most of these cases are diagnosed clinically. If you go to the classification, it can be congenital or acquired, which can be again of different types, and always consider conditions which may mimic ptosis, which are called the pseudotosis. So a clinical evaluation of ptosis should start from the history as for any other case, as of the age of onset, duration, whether it is present in one or both eyes, whether there is any variability, decreased vision, diplopia, any abnormal head posture, history of any body muscle weakness, history of surgery, trauma, and if the patient is not giving a proper history of when it has occurred first, you can go through the previous photographs, which will help you, as in this case, as to when is the average time of onset and whether it is progressive or not. When you consider conditions which may mimic ptosis, the most common conditions are dermatochalasis, inophthalmos, artificial eye, where because there is no support to the lid, it droops down, and in hypotropia, as you can see in this eye, in hypotropic eye, the lid also droops down along with the globe, and when you try to make the hypotropic eye to fix, the ptosis improves. Blepharospasm and contralateral lid retraction also has to be considered. Now, this gives a checklist for the ptosis evaluation. First, the laterality, whether it is unilateral or bilateral. Any swelling or mass in the lid which can lead on to a mechanical drooping which produces a mechanical ptosis. And this is the array of checklists which we will go through one by one. Normally, the upper eyelid covers 1/6, the upper eyelid covers 1/6 of the upper cornea, that's about 2 millimeters. When it is more covering the cornea, then you call it as ptosis. And one important thing what you have to look is the lid crease. In congenital ptosis, the lid crease might be absent or it might be a very faint lid crease, whereas acquired ptosis have got usually a well-formed crease. Now, measurement, another one is important, is the marginal crease distance, which is the distance from the highest point on the upper eyelid to the most prominent fold on the upper eyelid, which is called the lid crease. And it is 6 to 8 millimeter in males and 9 to 11 in females. When you take different lid measurements, it is important to note that the patient should be looking straight in the primary gaze without any neck flexion or extension. The eyebrow should be relaxed to negate the action of frontalis muscle. One important measurement is the palpebral fissure height, where it is a distance between the upper eyelid and the lower eyelid margin in the center. It is 8 to 12 millimeter in females and 7 to 12 millimeter in males, which we can measure with a measuring scale. This again has got two components, the MRD, marginal reflex distance 1 and 2. MRD1 is the distance from the corneal light reflex to the upper lid margin, and 2 is from the corneal light reflex to the lower eyelid margin, and MRD1 plus 2 will give the palpebral fissure height. Lid margin, if the lid margin is above the light reflex, the MRD1 is positive, and if it is below, it is considered to be negative. You should also measure the palpebral fissure height in the down gaze, which is usually 5 to 6 millimeter. In this photograph, you can see the palpebral fissure height when you on down gaze, that is less when it is compared with the normal eye than in the primary gaze. This is because in this case, in acquired aponeurotosis, because of the thin and stretched muscle, the muscle gets relaxed and droops down so that the lid comes to a lower position. Whereas in congenital ptosis, where the muscles of eyebrows contracted and tethered by fat and all, the muscle will not relax and droop down. So the palpebral fissure height in down gaze will be more when you compare with the normal eye. When there is a unilateral asymmetric ptosis, a difference, it is graded as, severity of ptosis is graded as 1 to 2 millimeter. When there is a difference of 1 to 2 millimeter is considered as mild, moderate is 3 to 4, and severe ptosis when there is a difference of more than 4 millimeter. One of the most important measurement what you have to make is the assessment of the levator function, which is usually done by the Burke's method, and this is always important to when it comes to your treatment aspect also. Now, the Burke's method, the patient is positioned against the wall so as to avoid neck flexion or extension. Now, ask the patient to look down in down gaze. You can keep a scale, and corresponding to the lid margin, you take the measurement. Now, block the frontalis action by the thumb, and now ask the patient to look up, and the amount of lid excursion, what has occurred, is measured off from the scale, and this amounts for the levator function. And in assessment of levator function, it is graded as, when the levator function is less than 4 millimeter, it is poor, 5 to 11 is fair levator function, 12 to 14 is good levator function, and if it is 15 and above, it is a normal levator function. As you can see in this picture, this is the initial measurement, and there is an excursion of 6 millimeter, so there is a fair levator function for this patient. In children and other patients who are not cooperating with it, you can also assess the levator function by what is called the ellipse test, where the upper eyelid is everted in down gaze. If there is a good levator function, that will revert back to its own. Checking for extraocular movements and pupil is also important in all cases of ptosis, especially to diagnose third nerve palsy and Horner syndrome. In third nerve palsy, the eyeball will be down and out. There will be ptosis, diplopia. The ptosis can be partial or complete ptosis. The pupil will be mydriatic with loss of accommodation. And in cases which is recovering, you can also get aberrant regeneration. In cases which may mimic INO, or when the ptosis is associated with an isolated cranial nerve neuropathy, always consider myasthenia in your mind. And mild ptosis with meiosis and anhidrosis, Horner syndrome comes into the diagnosis. Bell's phenomenon and lag of thalamus is also important in cases of ptosis, where there is up and out rolling of the eyeball and forceful closure. So when there is a poor Bell's phenomenon and lag of thalamus, whenever you do surgery, there is always a risk of postoperative corneal exposure, which has to be considered. Marcus-Kahn jaw-winking phenomenon is associated with certain cases of congenital ptosis, where there is retraction of the ptotic lid on stimulation of the pterygoid muscle, which can be done by opening the mouth or contralateral movement of the jaw. And with small children, you can even give a piece of candy or chocolate to them, which they will be chewing, and small infants, even during breastfeeding, you can elicit this phenomenon. In patients who complain of variability in the ptosis, especially if it is worsening in the evening, with history of sudden onset diplopia and systemic symptoms like swallowing difficulty with solids, these are all red flag signs where you will have to consider myasthenia into your diagnosis. And in myasthenia, the levator function will always correlate with the amount of ptosis. A normal levator function with marked ptosis is always against myasthenia. It will always correspond to the amount of ptosis. Now, to go more into the diagnosis, you can elicit the fatigability test, where the patient is asked to look forward and you note the lid position. Then the patient looks down, the patient looks up for 20 seconds. After that, you measure the amount of ptosis. If there is an increase in ptosis, myasthenia gravis is the possibility to be considered. Peak sign, when the patient tries to keep the eyelids closed, the palpebral fissure will slightly open. This is because of orbicularis weakness. The eyelid slowly separates as if peaking with one or both eyes. That is called the peak sign, which is again what you get in myasthenia. Cogan lid twitch, or the palpebral jitter, which the patient looks down for 10 to 20 seconds, and then the patient is asked to rapidly refixate to the primary position. The lid will slightly overshoot before it comes back to the ptotic position. So that is Cogan lid twitch sign, again in myasthenia. Now, the diagnosis can be confirmed by using an ICE test, which is it can be done as an office procedure, and it has got a 90% sensitivity. It is a safe alternative to the Tensilon test. If you place ice pack for 2 minutes on over both the eyelids, if there is resolution of ptosis after 2 minutes of application of ice, the ice test is said to be positive, as you can see in this picture in these two patients. And an alternative, what you can do is a sleep test where the ptosis improves after a period of sleep. Herring's phenomenon or enhanced ptosis, where this is usually can be elicited usually in case of asymmetrical ptosis. In this you can see that there is an increased ptosis in the, I can take 1 minute more. There is an increase in ptosis in the right eye. It is an asymmetric ptosis. So if when you lift the eyelid on the right side, you can see there is a drooping on the other contralateral side. So this always has to be elicited, and the patients has to be told about the need for ptosis surgery in the other eye when you take these patients for surgical procedures. And this is because when the frontalis gets relaxed, there is decreased innervation going on to the other side. So in this patient, the surgery was done for a moderate ptosis. In the right eye, it has improved, but after surgery, there is a mild ptosis has come in the other eye. This always should be explained to the patient beforehand itself, or else you will be in trouble. So, a proper history and evaluation of ptosis with all measurements and signs elicited will help to diagnose the type and tailor your investigations accordingly, and also to take appropriate treatment decisions. Thank you.
Thank you, madam, for this elaborate talk and explanation.